Here we're removing a crown from a single tooth, and as you will note, once the crown is removed, a vertical fracture becomes apparent. The tooth is extracted, and now the intactness of the facial plate is being evaluated. Once we find that the facial plate is intact, the next thing we do is look at the relationship between the free soft tissue margin and the crest of the intact facial plate. That is going to serve as our guide for implant placement. Here we are beginning our implant placement utilizing a spear point burr. We now, utilizing our philosophy of undersizing, are beginning to slightly expand the osteotomy site with a 2 millimeter twist drill. We are taking it to depth, always keeping in mind that the implant needs to be tucked behind the facial plate of bone. Verifying the position of our implant utilizing a guide pin. Since we are going to be using a tapered implant to maximize primary stability, we begin preparing the site with a 3.25 millimeter shaping drill. And again, always preparing the site so that the implant will be tucked behind the intact facial plate of bone. Verifying the site with a 3.25 millimeter direction indicating pin. We are now going to expand the site using a 4 millimeter shaping drill and taking it to depth. Verifying the site once again. And now finally expanding the site using a 5 millimeter shaping drill, always being careful to prepare the site so that the coronal portion of the implant is always tucked behind the midfacial plate of bone. If the midfacial plate is compromised, and by it being compromised we would have to place the implant too deep, in my opinion, that then becomes a poor candidate for immediate placement and becomes a candidate for site preparation prior to implant placement. Here you can see our tapered implant, and it is being inserted at 40 RPMs with an insertion torque of 50 newtons. You will notice that the implant stalls out long before it is finally seated. What we are going for here is maximizing primary stability. We will then finish seating the implant utilizing a hand ratchet. And I want you to notice how aggressively we are utilizing the hand ratchet to make sure that this wedge-shaped implant is completely seated in the wedge-shaped osteotomy site. This implant has also been treated with a nanotight nanobiologic surface. So here we are establishing high primary stability You'll note that with the Ostel device, our initial primary stability is 82, which is extremely high. Notice that the abutment that we're selecting for this immediate load project has a 4.1 millimeter platform, even though our implant has a 5 millimeter platform. Platform switching for two reasons. Mechanically, centralizing occlusal forces. Later, biologically, preserving crestal bone. The tooth is then restored on this provisional post. We then wait 8 to 12 weeks and move forward with our restoration. Here we are trying in our crown. Notice that we put two little wings on the crown so we make sure that it's being seated properly apico-occlusally, and then the wings will be removed. Our abutment is adjusted extraorally. It is seated. Our crown will be tried in and cemented in place. Here is our temporary abutment seated. The crown is tried in. So here, we're just going to seal the access cavity in this temporary abutment. The temporary abutment that we use is made of polyether ether ketone. It's inexpensive, it's stable, and it's utilized during the initial healing phase and to get us through the transition from mechanical to biologic stability. Final try-in of the crown. We very much like to make our provisional crowns with these two little wings on them to initially position the crown properly and make sure that everything fits passively. And then, as previously stated, we will cut off the wings before we deliver the final restoration. The abutment is lubricated. The shell is filled with acrylic, seated in place. The wings are now cut off the crown, and it is seated in position. The last step involves the placement of a non-absorbable bone graft between the buccal surface of the implant and the palatal surface of the buccal plate. We believe here in using a non-resorbable material because if this microgap is not packed, it is not an issue of the gap not filling with bone, it's an issue of the way that microgap fills with bone. That microgap will fill with bone by the buccal plate moving back toward the implant. If we do not fill that microgap with a non-resorbable material, then over time, the facial soft tissue covering the implant will collapse toward the palate. So I like to call this non-resorbable bone graft the breast implant of implant dentistry. By that I mean that this material is put in there to maintain the illusion of the buccal plate being far to the buccal and therefore improving the aesthetics of the situation. A small piece of collagen sponge is inserted on top of the graft. It is simply tucked under the flap. This is not a regenerative membrane. This little piece of collagen becomes a graft containment device. The crown is then seated and the case completed. I want to thank you for giving me the opportunity via Dental XP for sharing some of my thoughts with you about the biomechanical management of implant dentistry and how the alteration of macro shapes and micro and nanotechnology will enable us to move forward and treat more complex patient subsets, achieving the objective of providing our patients with fixed restorations in a less invasive manner sooner. Thank you.